Thank you very much, and thank you for the introduction. I have to say, I'm really, really pleased to be here. This is a very unique conference, and the one 3 years ago, was pretty amazing. It's very unusual. People say they do these kind of conferences, but they don't, where there's jointly, medics present, there is patients, families, and pharma equally contributing. So I think it's a very, very unique conference, and I'm very pleased to be here. So I'm going to talk about amyloid neuropathy in the era of treatments, which is, of course, where we are now, and these are my disclosures. And I'm going to give a very brief introduction, very brief, because not everyone was here 3 years ago, and I am the first speaker. Then I'm going to talk a little bit about the neuropathy, but mainly focus on the neuropathy in the era of treatments. So TTR is a small protein. Most of it is produced by the liver, as you can see here, and it does very little in the periphery. It carries a small amount of thyroxine, which you don't need it for, and it carries bound vitamin A, and those of you on treatment to suppress it know you have to take vitamin A supplements. There's about 130 pathogenic variants in the hereditary type. But the important thing about TTR is it's intrinsically amyloidogenic. So the structure of the protein means it does tend to form amyloid. So an emerging problem, and a really quite big problem, is the wild-type TTR, which I'm not going to talk about, but you will hear about today, because that predominantly presents with a cardiomyopathy later in life. But also it loves the connective tissues, so it's a very big cause of carpal tunnel syndrome and spinal stenosis. But neuropathy is less common. Although everybody over the age of about 100 has wild-type TTR. And if we all live to 120, we probably all will have neuropathy. So it's a disease that comes to everyone with time. That's why we're seeing more of it. The one I'm going to focus on today is the hereditary type, where you have a variant in the protein. And there's many different variants described at this stage. And the most important thing I think to take home today is this is a systemic disease. One of the worst things that's happened in this field is people talked about familial amyloid polyneuropathy and familial amyloid cardiomyopathy, whereas it is a systemic disease and it can affect any part of the body. And that is really important treatment-wise. And if people had thought that way 20 years ago, we wouldn't have patients who cannot get treatment just because they have heart or just because they have nerve. So that's been a real issue, which is still not addressed. And companies are still doing trials not taking this into account. So the very simple way of looking at the pathogenesis, and I won't dwell on this, is most of it is produced in the liver. It exists in a stable tetramer form in the circulation, but even the wild type has a tendency to dissociate into monomers. And if you have a variant, that happens more quickly. And these monomers can misfold and cause amyloid fibrils. And it's a particularly delicate. It likes the connective tissue, that is carpal tunnel syndrome, the heart and the peripheral nerves. But it can affect anywhere, but they're the main places it does. And what's changed completely is that we now have treatments. That is what's changed in the last few years, or the last 10 years, but particularly in the last 5 or 6 years. And that's changed this disease. Because this is now a treatable disease, and that totally changes the way both us and families and potential patients look at the disease. So in terms of the neuropathy, people think of hands and feet. And that is the peripheral nervous system. So you have weakness or you have numbness, loss of sensation. But there's also the autonomic nervous system that Sinead is going to talk about a bit more. And the autonomic nervous system can present in a very diverse way. It can present with postural hypertension, but it can also present with cardiac symptoms, and hugely can present with gastrointestinal symptoms. So when you have diarrhea or constipation, it can be the autonomic nervous system, and it can be direct infiltration. So the presentation of neuropathy can be very diverse, and therefore it can get missed. And the original description was in Portuguese patients in the 1950s, and these were younger. These were people in their 20s and 30s, so they weren't people with mixed disease. They presented with a neuropathy. It was found to be dominant. It was described by Andrade. They had autonomic dysfunction fairly early, but the cardiomyopathy came much later, and the prognosis without treatment when they were originally described was about 10 years. In terms of the classic way they presented, so we all learned that the classic presentation is with a painful small fibre neuropathy. So the Portuguese early onset do present with pain, but with time the neuropathy spreads to involve arms and legs with loss of feeling, numbness, weakness, autonomic neuropathy and cardiomyopathy. And untreated, the patients that we don't see now, luckily, years ago you would see patients bedbound from the neuropathy with constant diarrhoea, supine hypertension, supine postural hypotension, and cardiac disease with massive weight loss with nutritional problems. And we don't see that by and large now. And of course, that is still the commonest one, the Portuguese one, not only because the Portuguese went to places like Brazil, but there's a reason why the mutation keeps recurring at that spot. And it's the second commonest cause of the neuropathy in the UK is the methionine 30, but it happens in older patients. But in the UK, what we see is the commonest one now, and I suspect this is emerging to be the same in most countries, is that the wild-type TTR is the commonest. So wild-type TTR, predominantly causing a cardiomyopathy, is the commonest. The second commonest we see in the UK is the isoleucine 122. Now, this is now called 142, and you probably will start getting mixed up today, because we all do. So 60 is now 80. 20 is 40. It's not like when you're 60, you do 40. It's the other way around. And it's just because of the nomenclature, they basically have a new way of describing it. I won't go into the reasons, but 60 is now 80, and you'll get your report saying that. So we're all trying to get our minds around the way of describing it. But the commonest one we see is isoleucine 122, and that's found in people of West African descent, and particularly in the UK Caribbean descent. And that is actually commoner than any other mutation, but again, usually presents with cardiomyopathy, and neuropathy is less common. And the average age of diagnosis is later. But we do see occasionally in neuropathy, this is a patient, and for those of you that know about DPD scans, sorry, the pointer isn't working. So basically, this is what a bone scan should look like, a DPD scan. You've no uptake in the heart. The second picture in is someone with typical isoleucine 122 with cardiac uptake. And the third picture was this patient, which just looked bizarre because it was all over the muscles, and the nerve and muscle biopsy showed diffuse amyloid. So you can get that. Now, there's a US paper that came out a few years ago that said with this variant, 90% of people have a neuropathy, and that is just not our experience. So we've recently looked at this, and what we had was an unselected group coming from the National Amyloid Centre to us, because in the UK until August 24, we had no treatment for the cardiomyopathy. So the way to get treatment was to diagnose the neuropathy. So all of these patients used to come with "find the neuropathy" written on the things. And when we looked carefully, we found that 40% of people with this variant have neuropathy. There is another 12% with neuropathy due to other causes, because diabetes is extremely common in this group. So, and the neuropathy is very mild, but it is there. But the commonest cause of numbness and weakness in the legs in this group is actually when they get it in their connective tissue. So as well as carpal tunnel syndrome, patients get spinal stenosis. Now, this patient doesn't have that variant, is a different variant, but this patient presented with spinal stenosis, had surgery, we found the amyloid, and it was 10 years later before the patient got the neuropathy. Now, they were on diflunisal, and that may have made a difference, but it was 10 years. But with the isoleucine 122s, this is the commonest. The commonest cause of neurological problems in the lower limbs is spinal stenosis. So that's a very common indicator that it may be. And, it may be in the future we just inject something in rather than have surgeons doing spinal stenosis surgery, but we're not there yet. So in terms of moving to the neuropathy, so the commonest variant in the UK and Ireland that causes neuropathy is what used to be called the ALA60 and is now called the ALA80. And this was the original data from the Royal Free. And when we looked at this in the UK, and this was Aisling Carr, who was working with me at the time and is now a colleague, we found about 50% of patients in the UK. So we have a lot of different variants, many of them very rare, but this is about 50%. And I was talking to Sinead earlier, and we were just wondering about in Ireland. I mean, I suspect it's much, much higher, but I don't know exactly the percentage, but it probably will be much higher than 50% in terms of it. So this is when we did some guidance to treating it in Ireland and England, and again to show the commonest mutations are the ALA80 or 60, whatever you want to call it, the 122 and the MET30. So the ones, it's the same group that we have in all of the UK and Ireland, but it bias more towards the ALA60 in Ireland. And of course, very briefly, the history of this is the families were originally described by Staunton in 1987. He showed they were due to TTR, but it wasn't until a few years later when the late Anita Harding in Queen Square, working with Staunton, found it was due to the ALA60 mutation. And of course, this mutation was originally described in the Appalachian region of the States, and the original founder of those families arrived in Ellis Island in 1845 at the time of the famine. So we know that this happened before that, thank you, but we don't know exactly when. It was sometime before the 1840s. What I did in the early 90s was visit many of these families and showed really that they were all there was a founder effect. They're all related way, way, way back. It could be 2,000 years ago for all we know. But that all of the patients so far around the world that have been described with the ALIS 60 probably have arisen from Northwest Ireland. There's no good evidence that it has arisen separately. So of course there's a huge number in Scotland, huge number in England. Australia has quite a big bit, and various places in the US. And it turns up occasionally in Europe, in Japan and various other countries. But places where you would predict it would turn up. And what's different about it? Well, first of all, our work showed, and this is changing, that the age of onset is different. This was 63, and I think it's drifting down as we're getting it earlier into the 50s. And 47% presented with heart and 41% with peripheral nerve. And that may change again because this was pre-MRI being done by everyone. So we don't know exactly, but it's definitely something that presents with a mixed phenotype. And I think it's really important that this is mixed. This is a disease that doesn't present just with a neuropathy or just with a heart cardiomyopathy usually. It is mixed. And some people don't even like using the term mixed now. We should just call it a systemic disease. And I think that is more accurate. And I think that's important because it is different than the Portuguese disease, and we need to keep that into account. And it is later onset. Autonomic involvement is often early and maybe the presenting feature. So the neuropathy often has autonomic involvement. And also there's early cardiac. And for some reason, to date, we've never seen a vitreous deposit. So we don't understand that, but it is something about the conformational change that doesn't give vitreous deposits, which is very common with other. So there are subtle differences. And if there's subtle differences in that, there probably are subtle differences in how it causes the diseases we know about and how we should be treating them. Now, we say reduced penetrance, but that's because it's a relatively late onset and people sometimes die of other diseases. But as people live longer, we don't know how penetrant it will be. But I certainly have particularly females in their 80s and 90s that carry the variant that don't have the disease. So it does seem to be, it is less penetrant in females. And with cardiac disease before treatment, this was a poorer prognosis. So people, it was between 3 and 5 years compared to the Portuguese. So it was a more severe disease. And what was different about it? Well, certainly with the neuropathy, less people present with pain. So if you're using that red flag that you have to have pain, you will miss patients. And it's my experience across TTR variants, the older you get, the less likely you're to have pain as the presentation and more likely to have numbness. And I think that's just aging nerves. But you do get pain, but it's not, if you're depending on pain, it's less than 50%. Whereas the vast majority of patients present with numbness or altered sensation. And again, as is common with many variants and many forms of amyloid, carpal tunnel syndrome is very common. So 70% of people had carpal tunnel syndrome, up to 13 years before the onset. Of course, I've always wondered, and I'm sure this will change in the future, we can diagnose, if you talk about Alzheimer's disease, or if you talk about neurodegeneration, there's a huge push now towards early diagnosis. How do you diagnose the disease before patients have symptoms? We can do it. We can do it 13 years beforehand and we don't do anything about it. So we can't treat now when we diagnose the disease. We wait for it to have affected the heart or the nerves. And actually that doesn't make sense. And I hope that will change with time. So what have treatments done to this? So how have treatments affected what we see with neuropathy? Because it has actually changed practice quite a lot. So when we think of treating genetic diseases, we think of, first of all, there are families. We find the causative gene. We spend a long time working out how that gene causes the disease. We develop candidate therapies, take them to clinical trials and have treatment. And TTR amyloid is one of the few diseases we've done the whole circle. So have we finished? Well, we haven't, but at least we've done the first circle. So it is a treatable disease, and why that's extremely important is early diagnosis becomes hugely important then, much more than it was in the past. And in terms of treatment, we have multiple different treatments, and this is going to be talked about by Julian Gilmore later. But the ones I'm going to mention are the treatments that suppress the production from the liver and stabilise the tetramer, because they are available, and Julian is also going to talk about all the newer treatments that are in trial going forward. Okay, but the original treatment was a liver transplant, and that was the first one was done in 1991. And that was a very good idea, remove the production of the liver, of the TTR from the liver, and see what happens. And people from Portugal, the young onset healthy people did very well. So remember I said the average prognosis was 10 years. Well, 78% were alive at 10 years and 58% at 20 years. So they did actually very well with treatment. But the Irish patients and many other later onset variants did badly because they probably had cardiac involvement and autonomic involvement, and we actually gave up doing liver transplants on the vast majority of those. The next group of drugs were the stabilizers. So they're drugs that stabilize the tetramer to try to reduce its dissociation into the monomer. And of course, diflunisal was one of the first ones of these, which is an old-fashioned non-steroidal, which actually is effective in the trial that was done. But it's not brilliantly tolerated because it is quite hard on the stomach, quite hard on the kidneys. So it certainly is in use and was in use in the UK when we had nothing else, but it hasn't been something that's taken off everywhere. But it is something that is used quite broadly. Tafamidis then was the next one. And tafamidis was shown, the original trial of low-dose tafamidis in neuropathy, the primary outcome measure wasn't met, but there were some secondary effects that worked, secondary outcome measures. So it was licensed in countries with young onset disease, but it was never licensed for neuropathy in the UK, it was never licensed for neuropathy in the US. So basically the overall opinion is that in the young onset Portuguese, if you do give tafamidis early, it does tend to delay progression. So it's still used in some countries, although I think talking to people, the feeling is they would prefer to use a more definitive treatment, but it's still in use. And also, of course, it's been licensed for cardiomyopathy at higher doses since then. Then the next one is acaridimus, which is the newer drug, and acaridimus has been shown to be helpful for the cardiomyopathy because that is what it was studied in, and I think it has been licensed in a number of countries now. And Julie will talk later about a new study that has just started, an international study, looking at this drug to try to see can you give it to people who carry the gene but haven't any symptoms, to see can it delay progression or stop progression or stop onset. And that's really interesting because that's an area we want to get things earlier and earlier, and Julie will talk about that later. And then moving towards the ones that really changed practice were the gene silencing. So if you look at these, the ones we talk about and the ones that are used routinely are the siRNAs and antisense. So both of these reduce the production of TTR dramatically, but have to be given repeatedly. And how often they have to be given depends on the drug. So these are drugs that work really well given repeatedly. And then CRISPR-Cas9 is a permanent way of gene editing. That's not available as a treatment, it's in trials. So it permanently stops. So this move towards stopping the production without having to do a liver transplant was been a huge change, and it's totally changed our practice. So if you look at the studies, I'm not going to go through these, the patisiran, the first siRNA, was an infusion, dramatic results. So the outcome measures, really, they weren't great outcome measures, but the drugs were so good, they did really well. So that was the first one. The second generation one is vutrisiran, which is a subcutaneous given every 3 months. As you can see, it suppresses the TTR just as well. This is the enotosarine, which is the original antisense. There was a little bit of a problem with thrombocytopenia and glomerulonephritis, and then there's the second generation, eplonterseran, which is being published a few years ago, which again is very effective at reducing the TTR and at the getting rid of the symptoms. And then the CRISPR-Cas9, this was the very first paper in the first 6 patients, showing that yes, it does gene edit, and yes, it reduced the production of TTR. And in the cardiac studies, they have shown over 24 months, it continues the reduction of the TTR. Now, obviously, we're waiting for all the final studies here with this. So we've very effective drugs to reduce the production and dramatically reduce the production of TTR. And what's emerging is, the more you reduce the TTR, the better. So if we think of AL amyloid, what we're doing is trying to get rid of the light chains. And it is the same for TTR amyloid. We know that if you reduce the TTR enough, you can stop the production of the amyloid. So what's happened in real life? So I think this is an interesting study. This is the long-term 5-year follow-up of patients on siRNAs. And that's actually where you begin to see some real data. So the first data I think is very helpful. It does continue to reduce the TTR. It stays suppressed if you keep measuring it. Such that if it's not suppressed, the first thing you say is the patient taking the drug. So that'll be the very first thing. There may be very occasional reasons otherwise, but that's usually the reason, although patients are very good at taking these drugs. But this is, I think, one of the most important slides. This is what happens to your clinical picture after years. So these are patients that were on the phase 2 and phase 3 trials of patisiran. And yes, they've had a slight progression, but overall it's fairly stable. These are the people on the placebo. So this is just 18 months to 2 years, these patients. So they've already deteriorated that much, and then when they get on the drug, they stabilise. So that is really critical. If nothing else, that's telling us you've got to start early. If you start months too late, a year too late, you've accumulated that deficit. And it'll be the same in the heart. And again, in the quality of life, it's exactly the same. So this is real data over 5 years in hundreds of patients. you have to start early. So if there's ever a question of any problem with people getting diagnostic tests, that's the graph. This is another real-life study, and this is actually even better in a way. So once you get out of trials, you go back to real life, messy life. And this is a messy Italian study, which I really like. First of all, I like it because it's got a huge number of variants, and only 20% of the Val-Met30. So we're dealing with the kind of stuff we see in a lot of, although there's no ALA60s there. Secondly, not everyone went on patisiran. There was people that went on tafamidis first. There was people that went on inoxaparin first, and then they went on patisiran. So that's real life. Not everyone starts the same way. And yet, there was nearly 200 patients. There was 181 patients in this study. They did show that most patients stabilised. Now, what they didn't have in this study is the TTR levels, unfortunately, but they did show most patients stabilised. A few didn't, which is interesting, and it does show in real life that if you treat, it's a very effective drug. So I think that's very useful. So in the UK, we've about 250 patients on treatment, and we're just putting together our data, which is to look over the last 5 or 6 years of patients in real life. But I thought I would just show a little bit of this data, and I particularly wanted to mention Luke, because I see him here. Luke had done some of this work. Luke O'Donnell was doing a fellowship with me, a PhD, and he's just become a consultant in Galway since August 24. And Niall Doherty, who's also here, I hope, who's doing a fellowship with us now and is actually from Derry. Niall is here somewhere. Hope. He's not actually putting up his hand to admit he's here. Okay. And basically, these are looking at our TTR ALA60 or 80 patients. And not everyone that's on treatment attends us. You know, they may come and be diagnosed, but then be attending us. So we've got 87 patients. 87 patients we're following up. And it's interesting, so 33 of those are asymptomatic carriers. Now, we'd have had no asymptomatic carriers 10 years ago. So patients want to be diagnosed early, so we begin to follow them up asymptomatically. And many of them then are on treatment. About 53 of them are on treatment. Now, a lot of people got put on treatment 2019, 2020, and then there was COVID. So our follow-up data is going to be really messy during that period. So we're just putting all that together. But I just thought I'd show you some patients. These are about 7 patients who have been on treatment. And the vertical lines are when they started. But this is the NIS total score. And as you see, it either improves or it stabilises. And again, if you look at the lower limb, it's exactly the same. And in my experience, when patients and when trials and when companies say it improves, what improves is not actually the neuropathy usually, it's the neuropathy symptoms. So some of the positive sensory symptoms, like the burning, like the pain, can improve. And there can be some improvement of the sensory involvement, but usually you're looking at stabilisation. So again, some of the patients now, we start treatment when they have a tingle in their toe. Of course, they're not going to improve if you have a tingle in your toe, but you'll never get anything else. So the better we are at treating earlier, we're really looking for stabilisation, and we should actually, ideally, be treating people when we have a marker of disease before they've developed anything. So we're not looking for improvement or stabilisation, we're preventing symptoms, and that's really where we're moving towards. And the quality of life is exactly the same. Now, the quality of life measures are always good, but they are a bit tricky. And this particular patient, as you'll see, everyone else gets better, and this patient does that. It's because other things can affect your quality of life. If you get another disease or something else goes on, those measures will change. So you have to be very careful using quality of life of what you're measuring. So if something else is going on in your life, that can make your quality of life very poor. So what we did show and what we've been able to do is we've been able to look at the actual neurofilament levels. And I'll come back to that because it's something we've been interested in. It's a marker of axonal neuropathy, a blood marker, we're trying to develop as a marker of early disease. And when we looked at it, when we looked at patients on treatments, there's about a 36% reduction per year when you give treatments. And if you look at this graph, this is very telling. So the amount of neurofilament reduction correlates with the amount of TTR suppression. So if less than 50%, you don't have much reduction. If you're 50 to 80, you have very good reduction. And it's greater than 80, you have huge reduction. So 2 things. You have to treat early, you've got to get your TTR really suppressed. That is how you treat this disease. They're the 2 things you really need to do. There may be other ways of preventing it, but that is current treatment. So early diagnosis has better outcomes. That's just not clinical trials. It's not just the extension studies of these trials, it's real life practice. So that's unequivocal that you have to treat early to get the best outcomes. So in terms of the criteria, what does that mean for us in practice? So as a neurologist, we still see people with undiagnosed neuropathy. Now, I still had someone in clinic a couple of months ago that is under neurologist, and this diagnosis has been missed for 4 years. So that still happens. So we still see it in undiagnosed neuropathy. But a move much more of what we do are people that have a cardiomyopathy, particularly the ALIS 60. So the kind of patients we all see, and the 122, it's they have a cardiomyopathy, do they have a neuropathy? Because you still cannot get gene silencing therapy unless you have the neuropathy. As I said, there's bizarre reasons for this, the way trials were done, but that is the truth. Then we're seeing early symptomatic gene carriers. So someone that carries the gene and they just don't feel quite right, or they have a little bit of numbness in their feet. And then we have the very early asymptomatic gene carriers. So this is the group we see quite a lot now. In the first group, the undiagnosed neuropathy, so we still do very standard stuff. So it's history examination, nerve conduction studies, neurophysiology to include small fibre studies and autonomic function tests. So that's the standard stuff we do, and that may be enough to make the diagnosis. In terms of other tests, we do use them when needed. And in terms of the neuropathy, the red flags are you won't think of the neuropathy, you won't make the diagnosis unless you think of it. So we still think small fibre symptoms are important. Not everyone, but 50% of people do. So someone that presents with a painful small fibre neuropathy. Neuropathy plus autonomic, if somebody doesn't have diabetes, it's amyloid to proven otherwise. It may be AL, but it's amyloid. There's very, very minimal differential for those two things together in the absence of diabetes. Problem with the isoleucine 1 to 2, they're nearly all diabetic. Previous carpal tunnel syndrome, especially bilateral, it's overwhelmingly common. I know it's a pretty common disease anyhow, but it's a massive red flag, and particularly it's been helpful with a cardiologist. For a neurologist, when you see someone with a cardiomyopathy and a pacemaker and they come to you with a neuropathy, that rings a big bell. And I think what I've changed recently, I really think severe weight loss. That's something that really rings, and sometimes it's not quite clear why. People come, they could have lost 20 kilo in a year, and there's no obvious reason. It's hard to differentiate why. That's a big loss. And then, of course, if there's a family history, it makes it much easier, or if certain ethnicities make it easier. And from my practice, everyone with an undiagnosed neuropathy gets TTR sequencing. As far as I'm concerned, it's a treatable disease, you can't miss it. So all of our patients get it. So 100% patients with undiagnosed neuropathy get it. So routinely in clinic we do this. It's a very easy test to do and we just do it. So in terms of the neurophysiology, there is a problem, a huge problem, is that it can look like CIDP, which is an inflammatory neuropathy needing immunotherapy. Studies in 2007 showed there was a 20% misdiagnosis rate. Studies 2017, there's a 20% misdiagnosis rate. And I would have patients, regularly misdiagnosed with CIDP. And this is still happening, despite all these papers. These patients are put on severe immunosuppressive drugs. Not only do they miss the right treatment, but they get treated with serious drugs. This is still a problem among neurologists. And this is really an algorithm that we did a few years ago about how to, I'm having great fun with this today, about how to diagnose the neuropathy. But basically, if you go through all the red flags and diagnose a neuropathy, if they have a family history and they have a DPD scan grade 2 or higher, and you'll hear about this later, we don't need tissue, that is a diagnosis. If they don't have a DPD scan of grade 2 or higher, we do need tissue. And it varies a little bit. And I think what I've kind of come to realise in the last year is there's no black and white rules. So we have rules we use, but there's no black and white rules. And I suspect even among us practicing here, it's not quite black and white. And we set up in the Peripheral Nerve Society, which is an international group, a working group, and we're putting together TTR diagnosis guidelines, which have brought out this problem. This is from internationally. And, for instance, if you're in Portugal and you're young, 20s, 30s, you have a positive gene test. If they show you have a neuropathy, that will get you on treatment. You don't need to show a tissue or a DPD scan. And that's completely correct in that group. In the Irish people, it is more difficult. They often have DPD, so you need to find the neuropathy. In the isoleucine 1 to 2s, you've got to show that it is amyloid neuropathy with a biopsy, skin biopsy, because they have diabetes very commonly. So how you diagnose it depends on the country you're practicing and the ethnicity and the variant. And I think there will be different rules. So what I'm getting at here, for Ireland and England, we need to be looking at gene-specific. Our group of patients are different than anywhere else in the world. We have the biggest concentration of ALIS 60 patients anywhere, and it is slightly different than all of the other groups. So with the other group, how do we do it early? So if that's how we make the neuropathy diagnosis in real life, I said the push is to earlier diagnosis, so how have we responded to that? Well, we still use the traditional ways, and it is quite common that somebody will come to clinic with a cardiomyopathy, and by using straightforward stuff, that is history examination, nerve conduction studies, and neurophysiology or autonomic function, we make the diagnosis. If they have a grade 2 DPD or higher, that's all they need, as long as there's no paraprotein or other cause of neuropathy. But increasingly, we're seeing patients with really minimal symptoms, and these tests are equivocal or they're normal. I use skin biopsy in this situation. The skin biopsy is a really nice way of looking at the very smallest nerves. These are the epidermal nerve fibres, and it picks up very early on whether they are reduced. And that is the gold standard for diagnosing a small fibre neuropathy. It is the gold standard, although when you say gold standard, you should be comparing it. It calls itself the gold standard because it's the best. Everything else is 50 or 60% as good as it, but it's the best way of diagnosing it we have. And you can pick up amyloid. So you do the biopsy. Sometimes you need the amyloid diagnosis and the epidermal nerve fibre reduction. Sometimes you need one or the other. So we have found that very helpful. So it was originally, a lot of the work done on this was done by the French in the methionine 30 patients. So they were a different group of patients, and it was found to be very high in the early onset patients. Many of them had amyloid, and even in the pre-symptomatic, some had. But in our practice, as we said, what happened is we had a huge increase in referrals once there was gene therapy available. So we started looking at it, and this is work done by Luke, which is currently under review. And basically, for the first just over 70 patients we did, these are patients whom we couldn't diagnose the neuropathy. They had symptoms, but we were not able to confirm it. And by doing the skin biopsies, either showing amyloid or reduced epidermal nerve fibre density, or both, we were able to get 33% of those patients on treatment immediately. And then we would follow them up and more. So that's been revolutionised our practice, skin biopsy. And it probably should be available in everyone that's looking after these patients. I know it's a bit controversial to say that maybe in the current audience, but it should be. It is the best standard of care at the moment. And what's good about what we've done is it is the patients we all see, ALIS 60, MET 30, 122. So this reflects what you and I are seeing the whole time. So what about novel markers? That's what we do now. Can we do better? So we need to be able to diagnose the neuropathy really early, and preferably when you carry the gene before you develop the symptoms. Now, it may be, if the trials work, that we actually treat people when they just carry the gene, but because not everyone will get the disease, or they may have some other problem, or they may, live to 70, 80, 90 and not get the gene, we need to have some markers. So we've had a particular interest in neurofilament light chain. Now, neurofilament light chain is one of the major proteins in peripheral nerves, and it's been studied in many diseases. And we initially looked at this some years ago, and we showed that in the TTR amyloid, neurofilament light chain is increased in the blood compared to patients without TTR amyloid. And it was also increased in patients with neuropathy compared to those with just cardiomyopathy. So initially it looked like it is a marker. What we next did is, in the patisiran trial, they looked back at they looked back at the blood samples, and this is quite dramatic. So if you look at the patients who were on placebo, the neurofilament continues to rise. If you look at patients on the drug, the neurofilament goes down. It stays down, and then when the placebo go on treatment, it comes down. So it's a good marker of disease activity and response to treatment. We wanted to see, could it predict disease? So what we did was, we had samples through the Royal Free of patients for the last 10, 15 years, and then we knew when they developed the neuropathy. So by looking at those samples, and this is a study that was not perfect because we didn't have samples on everyone at every time point, but basically we show that there's a trend towards an increase in about 70% of your neurofilament levels in the 6 months before you develop the neuropathy. So it's looking promising as a marker. It's still in investigation, but it is looking promising. We then developed MRI, and this is for a different disease. So this is looking at MRI muscle. So if you denervate your muscle, you accumulate fat in the muscle. This is some with a different disease, Charcot-Marie-Tooth disease. This is a very mildly affected, this is a moderately affected, and this is severely affected. And I think it's very useful to look at this. If that's your muscle, you're never going to get better from that. The best you do is stabilise it. If that is what happens if you don't treat a neuropathy, the muscle is completely, the fat completely takes over from the muscle. And then we developed over multiple different types of hereditary neuropathy. We showed this was really sensitive. Now, we weren't able to look at TTR amyloid, and the reason we weren't is the ALIS 60 patients, most of them had pacemakers and defibrillators. So we weren't able to do it because they weren't able to have scans. But the French group did do a small study where they looked at 15 patients, of which 10 of them had the MET 30, and showed it's equally sensitive over the first year of treatment. But what we don't know is it more sensitive than other markers pre-diagnosis. I think it won't be, but we don't know yet. And then some other groups have started imaging the sural nerve. Now, for neurologists in the room, the thought of doing an MRI in the sural nerve and to pick up a neuropathy in the sural nerve by MRI, that's like almost fantasy land. We need to be doing 7 Tesla, 11 Tesla. So what do we need? So we need more data on skin biopsy versus neurofilament. Nobody's done that yet. We're doing it now. So we now have neurofilament available as a routine test. We do it on everyone at every visit. But we do it as a research tool. We're not using it to inform decisions yet. So we need to see which is more sensitive in the ALA 60 population, not the MET 30, but in this group of patients. What should we be doing very early on? We are looking at other biomarkers. We're studying a biomarker called peripherin, which is a really lovely biomarker of axons, only in the peripheral nerve. You don't get it in the CNS. It's a very specific one, and we're looking at periaxin. We need to look at early autonomic markers. We need to look at other markers of MRI. Look at what they've done with the heart. They're fantastic at the imaging of the heart, but that's a big chunky organ. It's not like little nerves, so it was easier to do. And we need genotype-specific data. So we need to be able to say, for ALIS 60, this is what you have done. For isoleucine 1 to 2, this is what you have done. And maybe Ashton's 110 patients have something else done. So we need to look at that. And that is because most of the publications in the world are biased towards MET 30. We need to be careful we don't take that too much on board and do our own work. The next thing is, how should we follow up our patients? And this is a huge problem because it's great having a treatable disease, but that means there's a huge number of patients attending your clinic that weren't, and people want to be diagnosed early. So we have sometimes patients who are 20 want an ALIS 60 genotyping done. What are you going to tell a 20-year-old in terms of their follow-up? You can't see a 20-year-old every year. They don't want to see you, and you shouldn't be seeing them. So you have to optimise your follow-up. With certainly people on treatment, we try to do it yearly. It's quite difficult. We either do it virtually or we do some of the alternate years virtually and see them in person. At the moment we do it clinically. We don't have the resources to do nerve conductions, autonomic, neurofilament. We do neurofilament in everyone, but skin biopsies. We just don't have the resources in normal practice to do this, but we probably should be doing this. But we need to exploratory what's the most important thing. And you know, sometimes life gets simpler. You know, with the gene silencing therapies, the best is probably the TTR level. So the TTR level marries everything else. If you get it low, you're treating the disease. So maybe that will be, and it's not that we can forget about everything else, but that is the absolute thing to watch it. And then we need to think of CNS, and finally going to talk about CNS screening. So we know, and we've always known, that 15% of TTR is not produced in the liver. It's produced in the retina and the choroid plexus. And it can cause a systemic disease. And I've had patients, and these are patients, some patients over the years, who present with a very serious disease, ocular leptomeningeal amyloidosis. This is a patient from many years ago. This is a patient actually that came from Ireland, but with a very rare mutation. And this is a more recent 17-year-old. This is the youngest patient I've ever had with this. And these patients present with CNS disease. It's a bit like cerebral amyloid angiopathy. So they present with amyloid spells, transient focal neurological episodes. They can have subarachnoid hemorrhages, they can have intracerebral bleeds, they can have hydrocephalus, they can have status, and they have cognitive decline. Now, these very rare patients, their variants in the TTR were so destabilising that the liver was very good at getting rid of them. And that's why you saw less cardiac and peripheral nerve disease, but you saw this very aggressive disease. And the reason why this disease is very important is because we don't have a treatment. And if we look at the TTR patients who had liver transplants, now remember, they'd have had their livers replaced, but they'd continually have production in the brain. And we wondered whether they'd get CNS amyloid. And after about a few years, they did indeed get retinal, so they got vitreous deposits, but they had no CNS disease. And it was 10 to 15 years later they began to get CNS disease. Now, the good thing is it does seem to be a much milder disease than the very aggressive variants, but people do get CNS disease with time. And the Portuguese have done studies, and these are post-mortem studies from years ago. And actually, you probably have very mild involvement in your leptomeningeal vessels and in other vessels, gradually increasing the whole time you've amyloid, but it isn't until you have 10 or 15 years of disease you get symptoms. And years ago, people didn't live that long. But that means everyone on gene silencing therapy is at risk of CNS disease eventually. So they're not yet, but eventually, 10 to 15 years. So we have to work out how we screen for these. And more importantly, we cannot treat it. So all of the gene silencing just work on the liver. You probably could develop an intrathecal one, and there's a lot of drug companies, so I want you to develop an allele-specific intrathecal ASO or siRNA, because you probably can't get rid of it completely, you do need some. The tetramers, by and large, don't cross the blood-brain barrier. Tafamidis, high dose, does about 1.5%. And a drug that we used to use for Parkinson's called tolcapone does. But at the moment, we have no effective treatment for this disease. we've been experimenting a little bit with looking at CSF. So this is one of my patients who has early CNS disease, and his MRI brain scan was normal with a tiny siderosis and leptomeningeal enhancement. And if you look at his CSF protein and his neurofilament levels, they seem to reflect disease, but actually we don't know whether that's there pre-symptomatically, so we don't quite know. But with this man, we've made the decision. We've had him on high dose tafamidis, which is what we do on everyone pragmatically that has this disease, and I'm now adding in talcapone on this patient. So we don't know how to treat this disease, but it's a very important going forward. And you know, it's some variants, like that girl I showed you that was 19, she presented at age 17 and was diagnosed as an autoimmune encephalitis. That's a very aggressive variant. So there are some very rare variants that are very aggressive. This is a big challenge for us. We've some years to sort it out, but at the moment we need treatment. So in the future, you would be on a drug that prevented you getting your amyloid peripherally, but also prevented you getting your amyloid in the CNS. And we've got to develop those drugs. So to finish, I told you there was a circle where we had got, but what we now realize is the minute you get to a treatment, you have more circles. So it's a continuous circle. When do you treat? Do we give a stabiliser and a gene silencing together? Should it be given everyone CRISPR-Cas9 editing, or if we have good enough stabilisers given less frequently, would that be good enough? We don't know. Can we find something that can give patients who carry the gene something to prevent the disease, or actually can we find a marker that tells us who with the gene will get the disease? And we need all of this to be gene specific. So to finish, there are two things to take home as far as I'm concerned with the neuropathy and TTR amyloid. First of all, it's a systemic disease. So in a way, talking about the neuropathy and cardiomyopathy separately is useful, but not, we have to remember it's a systemic disease. All about early diagnosis. And if you're gene silencing, it's all about how much you can suppress the TTR. So just to finally say, this is my team in Queen Square. This is the hereditary neuropathy team, and it's a bit messy because some people are at it and we haven't got an up-to-date picture, and our physicists refuse to ever come and be photographed. They just only send their pictures. They never will do it. And we work extremely closely with the Amyloid Centre, and with Julian and I have worked extremely closely for many years. And he has very nicely put me on his list of people. He used to give me some money yet, but you know, that's fine. At least I'm there in it. And finally, all my funders. Thank you very much.